really a thrill to be here, especially because when I told my lab that I was going to get a chance to speak at a TEDMED conference, the graduate students and the postdocs finally thought we were doing something that was pretty cool. So I have the privilege of picking up where Greg left off and really talking about the clinical research in humans of how we work on early diagnosis and ultimately the treatment of Alzheimer's disease. Now, I want to say that although you heard some incredibly staggering statistics from Greg, I want to argue that in fact this is really just the proverbial tip of the iceberg. And you've heard lots of analogies today, bombs and tsunamis. I'm going to use the iceberg because by the time that the symptoms of Alzheimer's disease have percolated up to the surface where we recognize it as Alzheimer's disease dementia, that process has been going on in the brain for 10, maybe even 20 years. And of course, we can't see what's underneath the surface, but it is heading towards us. Now, if you took that iceberg and you turned it over on its side, it might look something like this. And down in the bottom corner is that tip we can see that we call Alzheimer's disease dementia. And this is what we all recognize right now as Alzheimer's disease. When people have lots of memory difficulty and they eventually progress where they can't feed themselves or can't dress themselves or where they can't recognize the person sitting next to them who's been their spouse for 30 or 40 years. And unfortunately, this is the stage of the disease where we are typically doing our clinical trials, where there's already been years of irreversible brain damage. Now, the good news is that over the past 10 years, we've started to move back up this trajectory, and we've recognized that there's an earlier stage, like prodromal Alzheimer's disease, often referred to as mild cognitive impairment. Now, at the stage of mild cognitive impairment, not all of these individuals will progress towards Alzheimer's disease, and in fact, not all of them have Alzheimer's disease as the cause of their memory impairment. But yet we know this is a significant risk factor, and 15% of them will move towards Alzheimer's dementia every year. And fortunately, we've already started to do clinical trials at this stage of the disease. However, I'm going to argue that unfortunately, even mild cognitive impairment might already be too late, because we know at the stage of MCI that 50 to 70% of some key nerve cells, some neurons, are already lost from these key memory networks that are so important for forming and retrieving new memories. So I'm going to argue that we have to go even further back up this trajectory to the stage that we've recently defined as preclinical or pre-symptomatic Alzheimer's disease. Now, when you get up to that stage of the process, of course, it's quite hard to recognize. We can't see it clinically because it looks just like normal aging. But the trick is we've got to develop methods, neuroimaging methods and biomarkers to really help us figure out who's on that nice, smooth sailing towards successful cognitive aging, those 1 out of 2, versus those who unfortunately are heading down the trajectory towards Alzheimer's disease dementia. And again, the trick is to find them and treat them before they get there. Now, this is a picture of, under the microscope, of a patient I took care of when I was a neurology resident who died of Alzheimer's disease at age 66. And this is the hallmark pathology that you heard Greg talk about, the plaques and the tangles. So those rounded orange-type things are amyloid plaques, and the dark triangular things are neurons with tangles inside of them, or a hyperphosphorylated form of tau. Now, we know in the field that amyloid must be something important in Alzheimer's disease because all the genetics drive us this way. But unfortunately, we don't really have all the answers. Now, don't worry, this is actually not a PowerPoint malfunction here. This is supposed to be a metaphorical black box. And in fact, one of the real mysteries in the field is how do we get from those plaques and tangles to the stage that we all recognize as Alzheimer's disease dementia, where people have cognitive and behavioral symptoms. And for this, we need a combination of imaging markers and lots of sensitive cognitive tests to help us illuminate this black box and, again, ultimately treat people before they come out the other end. Now, we've had a great leap forward in our ability to detect Alzheimer's disease in the living brain over the past few years. And this is with both biomarkers and evidence on a new imaging technique in which we can actually take a tracer and look for those amyloid plaques not under the microscope, but in the living brain using a special dye and a PET camera. And as you may have heard on the news, because it certainly hit the Wall Street Journal, last Friday, the FDA approved the first ever PET amyloid imaging for clinical use. Now, excitingly, we've been able to start to do research with PET amyloid imaging, and as you can see on the top row is what a typical normal older individual looks like. So they don't have any amyloid, or at least not much in their brain that we can detect. All of that blue is non-specific binding in the white matter. On the bottom row, you see a typical, very mild Alzheimer's disease patient who already has shown in pink and yellow amyloid plaques all over their cortex, or the gray matter, in parts of the brain that are very important for thinking and memory. Now, as we've started to do research on this across all types of different groups, it's been remarkably consistent. So these dots in the scattergram I'm showing you here, you can see in the Alzheimer's disease patients, the vast majority of them have evidence of amyloid pathology already. When you look at the stage of mild cognitive impairment, it's about half and a half. And 60% of MCI subjects have evidence of amyloid that's already up in the levels of Alzheimer's disease, and about 40% don't. And we already know that those who have amyloid pathology are 5 times more likely to move to AD dementia than those who don't have any amyloid. And in fact, it looks like those MCI subjects who don't have amyloid probably don't have Alzheimer's disease as the cause of their memory trouble. But what's really exciting is actually over there in the group called normal controls. These are individuals that we picked to be the normal controls in our study. And we noticed, lo and behold, about 1/3 of them have evidence of amyloid in their brain. And it's exactly in the same areas that are seen in Alzheimer's disease dementia. Now, you might say, well, what's up with that? How can it be that amyloid causes Alzheimer's disease if you can walk around with a head full of amyloid and still be normal? Well, here's an idea. One possibility is that we're looking at preclinical Alzheimer's disease, the very beginning of the process. And this doesn't actually require that amyloid causes Alzheimer's disease, because we don't know that yet. But maybe it sets the stage. Now, here's that curve shown in red that Greg just showed you, exponentially of Alzheimer's disease as we get older. And shown here in green is the curve of the likelihood of having amyloid in your brain. And this we've actually known from autopsy studies for many years. And superimposed on this, or the blue dots, are PET studies. So the likelihood of being amyloid positive and still being normal. And now we don't really yet know whether those individuals who are there on the blue dots, in fact, are going to progress and move over to the stage of Alzheimer's disease dementia. But we've started studies already. And our models suggest that it's about 15 years from the time that you might develop amyloid plaques in your brain to the time that you develop Alzheimer's disease dementia. Now, this may sound crazy, but think about cholesterol plaques in your heart. Well, we know that lots of people have cholesterol plaques in their heart vessels and their aorta years before they ever develop a heart attack, but we still try to get rid of them. Now, in order to really understand what happens with amyloid and whether this really affects the brain, I have to turn to another form of imaging called functional MRI. And in this way, we can actually look at how the brain works when it's doing exactly the kind of problem that older people complained about in terms of their memory. So we study how people remember names and faces. So I'm going to give all of you a little bit of a memory test. I know it's late in the day, but let's see how you do. So I'm going to show you the kinds of faces and names that we show people. We put them in a 3 Tesla magnet. We show them lots of face name pairs they've never seen before. And we explicitly ask them to remember the face name pairs while we're imaging them, because we're going to ask them later to tell us which name went with which face. Now, this is a very difficult memory task, especially when you only get 3 seconds to do it. So who was this? Very good. Okay, even this late in the day. Great. So in fact, at the time you were forming that new face name association for that 3 seconds, your brain was working in a very integrated fashion, where the networks that you heard about from Greg had to work in a very integrated, coordinated fashion to form this memory. Now, the part of your brain that's very important for memory, the hippocampus, if at the time you were learning Lauren's name, and then I asked you 30 minutes later to remember it, if your hippocampus was working well, it does what it shows here in yellow. It turns on amazingly well. If you said, I think that's Lauren, I'm not so sure, it turned on, as you can see here, in pink. And if you're like me, and you could say, oh, it's Lauren, it's Emily, it's Ted, I have no idea. Unfortunately, your hippocampus failed to turn on, as shown here in blue. And this was the first clue that maybe we could look at the living brain and see when memories are successfully formed, and unfortunately, when they fail. So we did a series of studies where we combined PET amyloid imaging and functional MRI during that kind of face name test, and we saw that the people who were amyloid positive but still normal already showed changes in their brain in these memory networks that suggested they were malfunctioning exactly as you see in Alzheimer's disease, but we could see this 10 years before they actually showed memory impairment. And in fact, we could see that not only with functional MRI, but with FDG PET, a way to look at how the brain uses sugar or glucose, and with structural or volumetric MRI, sadly, we can already see that there's shrinkage of the brain beginning in these areas before people get symptoms at all. Again, arguing that if we're really, really going to save people's memories, we're going to have to go even before this stage. So let me turn next to the last question, which is the thing I hear most when I talk about a preclinical stage of Alzheimer's disease, which is why would you possibly want to detect and find out that someone's going to get Alzheimer's disease 10 or 20 years before they do when there's nothing we can do about it? Well, I'm going to argue that's exactly how we're going to do something about it. Because if I look at the other diseases that have been talked about here today, and I think about why we've had successes, it's because we've treated early and ultimately moved towards prevention. So think about these diseases if we wait until the symptoms are already clinically evident. In cancer, in heart disease, in HIV/AIDS, diabetes, osteoporosis, stroke, any of these, we have successes when we treat before we can see symptoms. In fact, after Francis Collins spoke today, I was trying to think about those 250 drugs that we have for the 4,000 diseases, and it was very hard to think of any of them that actually work after there are symptoms, except maybe Viagra. And of course, I've been thinking a lot about that since that great penis talk. But it turns out again that the likelihood is that we're going to have to go much earlier in this disease if we're really going to bend the curve. Now, what we have today in Alzheimer's disease is symptomatic therapy. And these drugs maybe move people up on the y-axis a little bit, and they treat the symptoms, but they don't really bend this curve. We're not fixing the underlying process of the disease. The holy grail, of course, is disease-modifying therapy, where we bend this curve and ultimately don't see a decline at all. But again, I believe that the way to do that is to go much earlier in the disease process. Now, the good news is, I think we do have biologically active drugs. We have them in the test tube, and we actually have some that are promising that are already in clinical trials. This is an approach using a monoclonal antibody or a vaccine to help that garbage truck that you saw, to help the brain empty itself of amyloid. And there have been now 2 studies suggesting in man that we actually can decrease amyloid burden that we can see on PET scans. But unfortunately, these 2 small trials didn't show any difference in the Alzheimer's disease patients who were already at the stage of dementia, who had already lost 70% of their neurons. So I think we're going to have to go earlier, but hopefully can use these biologically active drugs. And that brings me to this idea of secondary prevention. Now, I hope someday we're going to have primary prevention trials for Alzheimer's disease, where we're going to have a safe drug, we'll put it in the water for everybody over the age of 30. But we're not there yet. Where we are is the ability to take people who have evidence of the disease beginning in their brain, but don't yet have any symptoms, and do clinical trials with biologically active agents to try to see if we can prevent the emergence of the symptoms. There are 2 approaches to this. One is genetic, going after individuals who have a rare genetic form of Alzheimer's disease, who get Alzheimer's disease early. And this was exactly the approach that we took in statins. We actually took statins into families who had hypercholesterolemia and showed that we could prevent their heart attacks and their strokes. And that's a good reminder for me quickly of how statins work. Of course, statins work very well if you give them before someone has a stroke or a heart attack. They even work if you've had just a little heart attack or a mini stroke. But statins don't do anything once we get to the stage of heart failure and you've had multiple heart attacks. And this is why, again, we're going to have to go before. So one of the most exciting trials are taking older individuals who have evidence of biomarker evidence of Alzheimer's disease, especially on a PET scan, and treating them with one of these drugs to see if we can prevent the emergence of symptoms. This is called the A4 trial, and there's more about that in my science kit. And we'll test the hypothesis that if we decrease amyloid burden, ultimately we'll prevent the downstream neuronal loss and cognitive decline. Now, this may sound frightening and heretical, but this is what's heading towards us. We can't wait. We've got to start these prevention trials now and see if at least we're on the right track. So I just want to stop with this. Who is this? Okay. So for those of you who thought this was TED, make an appointment with me after the session. Thank you very much for your attention.